Hi all, my name is Zachary Miller, and today I'll be discussing the issue of conflicts of interest in healthcare ethics consultations. Before we begin, we should discuss what exactly is a healthcare ethics consultation, or HCEC. According to the American Society for Bioethics and Humanities, or ASBH, a healthcare ethics consultation is a set of services provided by an individual or group in response to questions from patients, families, surrogates, healthcare professionals, or other involved parties who seek to resolve uncertainty or conflict regarding value-laden concerns that emerge in healthcare. An HCEC can be provided by either a healthcare ethics consultant or a healthcare ethics committee. As both consultants and committees provide the same resource in HCECs, they'll both be referred to as HECs in this presentation. Now that we know what an ethics consultation is, we should describe the origins of the ethics consultation. In 1960, Belding-Schreiber's Teflon arteriovenous shunt was invented. This shunt allowed for permanent access to a patient's veins. This therefore allowed for more patients to be able to undergo hemodialysis. Yet, having more patients being able to undergo hemodialysis strained the resources available to hospitals, requiring them to determine who may receive this life-saving treatment. From this need to determine who should get treatment, the Seattle Artificial Kidney Center at Swedish Hospital developed their Admissions and Policies Committee. This committee was made up of 7 individuals: a lawyer, a minister, a banker, a housewife, a state government official, a labor leader, and a surgeon. Due to the nature of the decisions made by this committee, the committee was nicknamed the God Committee. With the origins of the ethics consultation, the advent of organ transplantation, living wills, and do not resuscitate, or DNR orders, had physicians in the 1970s repeatedly running into legal and moral dilemmas. To provide guidance to these physicians, hospitals began slowly adopting the idea of ethics committees. Medical schools also began adopting medical ethics into their curricula, and from this the idea of ethical consultants arose to provide physicians with guidance into complex ethical issues. The American Society for Bioethics and Humanities, or ASBH, was established in 1998 with its Healthcare Ethics Consultants Certified, or HEC-C, certification program being established in 2017. Research done by Fox et al. That is presented in Ethics Consultations in U.S. Hospitals, a national follow-up study, showed that 86.3% of all U.S. general hospitals provide some form of ethics consultation services. Yet despite this, multiple issues have been identified with HCECs. One issue that has been described, yet remains stubbornly unresolved, is who exactly the client of an HCEC is. Specifically, who does the HCEC serve, the institution or the patient? In order to identify who an HEC serves, we should look at who benefits from an HCEC. With this, we'll be looking at the benefits to both healthcare institutions as well as patients. The benefits to healthcare institutions are as follows. The HEC can help physicians make better ethical choices. HECs can also encourage physicians to reflect on the role of ethics in their healthcare practices as well as in their personal and professional lives. HECs can also help promote change within institutions that encourage better and more ethical decision-making. Finally, HECs can help resolve conflicts in a way that doesn't simply promote agreement between parties, but helps promote ethical decision-making within disagreements between parties. The benefit to patients are as follows. HECs can help promote patient autonomy. HECs can also help empower the voices and decisions made by both patients and their surrogates. Finally, HECs can help resolve the imbalance of power between patients and their physicians. As can be seen, ethics consultations can provide benefits to both the healthcare institution as well as patients. Yet, what exactly happens if the interest of the healthcare institution conflicts with the interest of the patient? Essentially, what we're asking is, who is the client of an ethics consultant? According to Christopher Myers in Clinical Ethics Consulting and Conflict of Interest, Structurally Intertwined, for an ethics consultant to do their job, the client can either be the institution or the patient. Instead, the client of an ethics consultant is the principle of doing the right thing. The ethics consultant cannot and should not take either side of the healthcare institution or the patient. Instead, the ethics consultant must guide decision making towards the best ethical outcome. Yet, can an ethics consultant serve the principle of doing the right thing if they are subject to institutional hierarchy? How can an ethics consultant claim to be unbiased and an unmotivated party, giving guidance through tough ethical issues if they are, themselves, a part of the institution they claim not to serve? From this, we should discuss what conflicts of interest are, and if healthcare ethics consultants and committees face conflicts of interest. According to the ASBH Code of Ethics and Professional Responsibilities for Healthcare Ethics Consultants, a conflict of interest involves situations in which the professional judgment of an HCE consultant is, or may appear to be, affected or compromised by competing interests such as personal, professional, or financial interest. For example, consultants employed by an institution may be reluctant to disagree with someone of authority and influence within that institution. They must handle the competing interest of preserving their employment and competently performing consultation. With this, the issue is that HECs cannot act as an independent or unmotivated third party while also being employed by, funded by, or in the case of healthcare ethics committees, established and ran by the institutions they claim to be independent from. As Myers puts it, do we really believe our position or training or character somehow makes us immune to having our judgment tainted? There is nothing to suggest a link between such training and virtuous character. By its very nature, HECs are at a high risk for conflicts of interest. Yet, do these conflicts of interest even matter? To determine the impact of conflicts of interest in healthcare ethics committees and healthcare ethics consultants, we should look at the case of Edna Foltz. In 1994, Marshfield Nursing and Rehabilitation was facing a difficult ethical dilemma. A discussion was taking place about withholding life support from one of their residents, Edna Foltz. Edna was 71 years old when she was first diagnosed with Alzheimer's. As her condition worsened, Edna became bedridden and required a permanent feeding tube in order to be given artificial nutrition and hydration. Due to Edna's worsening condition, her sister and court-appointed guardian, Betty Spahn, requested withholding of artificial nutrition and hydration. Betty stated that the continuation of life support was not in the best interest of Edna, as Edna would not have wanted to be given life support. From this situation, the Ethics Committee from Marshfield Nursing and Rehabilitation met to discuss what their decision would be regarding Edna. From this discussion, the decision was made that there would be a withdrawal of life support if no family member objected. Yet one niece of Edna's refused to sign the statement agreeing to the withdrawal of life support, and thus it was decided that Edna would be kept on life support despite their guardian's arguments about how the withdrawal of life support was in the best interest of Edna. Following the decision of the Ethics Committee and legal arguments made in this case, a review of the situation and legal decisions was provided by Circuit Court for Wood County Judge Dennis D. Conway. Judge Conway found that in this case, the Ethics Committee acted in a way that insulated the facility from legal liability rather than the determination that best comported with medical ethics. Furthermore, Judge Conway supports his belief that the Ethics Committee acted to protect the institution from legal liability, stating that the Ethics Committee apparently agreed with the decision to withhold nutrition from Ms. F, but would not agree to carry out this decision without written consent from all family members. It appears that all family members except for one niece of Ms. F consented in writing. The niece was reported to have said that she did not object to withholding nutrition, but that her religious views precluded her from consenting in writing. The circuit judge concluded his own lengthy questioning of one member of the Ethics Committee with the following. The way I understand it, what you really have is a liability problem, and that's why you want everyone to consent. Is that right? Dr. Erickson answered, that is correct. In reality, whether Judge Conway is right that the Ethics Committee only acted in the interest of the institution over the interest of the patient Edna Foltz does not really matter. If they did act in a way to put the interest of the institution first, then this represents a conflict of interest. If the actions of the ethics committee was truly in the best interest of Edna, but the committee's connection to the institution makes the decision appear to be biased as it did to Judge Conway, then that still is a conflict of interest. In either case, the connection the HEC had with the institution created either a real or apparent conflict of interest. While this case is unique and complicated, at its heart it represents the issue that HECs face with conflicts of interest. The HEC relies on the ability to provide unbiased guidance through ethical issues. Yet, these conflicts of interest erode the ability of HECs to provide unbiased guidance and therefore risk losing patient trust. Furthermore, as seen in the case of Edna Foltz, conflicts of interest within HECs risk creating real or apparent harms to patients and may create or prolong suffering to patients. Now that we understand the issue of conflicts of interest within HECs, we should discuss ways of dealing with these conflicts of interest. According to the ASBH Code of Ethics and Professional Responsibilities for Healthcare Ethics Consultants, HCE consultants should minimize the likelihood that conflict will interfere with their duties towards those who seek their advice and support through HCEC. Principal strategies include avoidance, recusal, and disclosure. An ethics consultation service with multiple consultants can, for example, assign cases with attention to avoiding conflicts. Consultants may recuse themselves from a consultation when another qualified consultant is available, or they may simply disclose the conflict. For example, some HCE consultants who are employed or paid by the facility where the ethics consultation request occurs disclose this potential conflict of interest to patients or family members at the onset of a case consultation. Consultants should make efforts to negotiate terms of services that minimize the occurrence of conflicts of interest and obligation and allow them to be managed appropriately. But the issue is, while disclosing conflicts of interest is important in maintaining trust and transparency, disclosure does not mitigate the impact of conflicts of interest may have on the HEC decision-making. Furthermore, it may not be possible for HECs to avoid or recuse themselves due to conflicts of interest due to limited institutional resources. Thus, even though the ASBH does provide beneficial guidances for HECs in managing and avoiding conflicts of interest, it does not address the intrinsic issue of conflicts of interest within HECs and healthcare institutions. Going back to Myers, they suggest 3 ways of dealing with conflicts of interest with HECs. Myers first suggests the idea of removing the healthcare institution's financial incentives with HECs. Myers puts forth the idea of HECs providing their guidance via a volunteer system and thus not receiving any funding for their work as HECs. Yet, Myers acknowledges that this situation is unviable, as it would be unethical to ask HECs to provide work without compensation, and that removing compensation does not eliminate all conflicts of interest as a whole. A second solution suggested by Myers is to have a disinterested third party provide funding to HECs. This would eliminate the conflict of interest that HECs and healthcare institutions have, but it's also not really impractical, as identifying a disinterested third party that's willing to pay for HEC services is unlikely. Myers' final suggestion, which is similar to the ASBH's suggestions, is to identify ways to manage these conflicts of interest. With this, Myers suggests 3 steps that should be taken. HECs must acknowledge the conflict of interest that they face, and must educate other HECs and healthcare institutions on the issues of conflicts of interest. HECs should also strive for independence and integrate the recognition of these conflicts of interest in their ethos, and avoid becoming a healthcare institution insider. Finally, HECs must be willing to take personal and political risks. Myers does recognize, though, that managing conflicts of interest only provides a band-aid solution for the issue at hand. Yet, Myers suggests that solving structural issues, such as those intrinsic conflicts of interest within HECs, would require someone to make an entirely new structure. From this information, one thing is clear. HECs are intrinsically at risk for conflicts of interest. Whether this be due to financial benefit from the healthcare institution or hierarchical structuring, these conflicts of interest can impact the decision-making of HECs and impact both the health and safety of patients facing ethically complex issues. Thus, it's important for HECs to recognize these conflicts of interest, disclose them as necessary, and take steps to mitigate these conflicts of interest. Yet, that's not enough in my opinion. Disinterested third parties such as the ASBH should continue to research this issue more thoroughly and provide clear and actionable guidance to avoid and eliminate conflicts of interest and their impact on HEC decision making. Thank you for your time. I hope you enjoyed this presentation.